everyone, and thank you for joining us today for Thrive Health's July Ground Round Speaker Series featuring CHEO. My name is Dr. Kimberley Kaseweter, and I am the Clinical Lead Researcher here at Thrive Health. Before diving in and introducing our speakers, we just wanted to open up with a land acknowledgement. Today we are hosting the session from the unceded and ancestral territories of the Anishinaabe Algonquin Nation in Ottawa, the Musqueam, Squamish, and Tsleil-Waututh Nations in Vancouver, and the Syilx Okanagan Nation here in Kelowna. We're lucky to have team members and attendees joining from other territories across North America as well. Again, welcome and welcome back if you have joined us for these sessions before. Today's discussion will be on thinking differently about innovation in healthcare. Just a few housekeeping notes before we begin. Please enter your questions in the Q&A tab here in the Zoom, and we'll answer them at the end of the session. We're going to do our best to answer every question, and I'll moderate the tab just to make sure we get all of the information. Please also note that the session will be recorded and that we will be live streaming on LinkedIn. So without further ado, I will introduce our speakers. We are grateful to be joined today by Dr. Matthew Bromwich. Dr. Bromwich is the lead and clinical director of the Innovation Core at the CHEO Research Institute. Dr. Bromwich is a board-certified otolaryngology surgeon, associate professor of otolaryngology, and a fellow of the Royal College of Surgeons of Canada. Dr. Bromwich is the inventor of several medical devices and holds 5 other medical patents. He aims to democratize access to medical care by delivering innovative and inexpensive solutions to global audiences. We're also joined today by Andrea Pepe. Andrea Pepe has her master's degree in neuroscience and is the Innovation Research Coordinator at the CHEO Research Institute. As a clinical researcher, her expertise lies in concussion rehabilitation. Her diverse background includes involvement in preclinical and clinical projects related to motor learning, pain, anxiety, depression, stroke rehabilitation, longitudinal lifestyle effects on cardiac outcomes, and innovative concussion recovery technology. Andrea and Dr. Bromwich will be presenting on thinking differently about innovation in healthcare. As I'm sure many of you know, bringing new, innovative technologies into the healthcare system can be challenging. While most people, especially those of you who are already working in healthcare, recognize the need for new innovations, there are still significant hurdles to overcome, such as funding, safety concerns, compliance barriers, and privacy, just to name a few. And it's because of this that Thrive is excited and grateful to have partners like CHEO who are approaching healthcare challenges and solutions with fresh, innovative perspectives, breaking away from traditional norms and embracing creative, out-of-the-box thinking for patients and providers to build stronger relationships. Like Thrive, CHEO is relentlessly focused on patient experience and is embracing technology to help revolutionize the delivery of healthcare, foster collaboration between healthcare professionals, and improve patient outcomes. So with that, I'm excited to pass it over to Dr. Bromwich and Andrea to expand more on this topic.
All right, can you see and hear my screen? You see me and hear the screen? You know what I mean? Amazing. So let's get started. So the title of this, I have actually since updated a little bit. It'd be called Rebellious Thinking. It challenges it a little bit more, and you'll see why that is. But innovation in healthcare is difficult, and it takes a lot to do. To translate anything into a real thing from an idea is difficult. So we're gonna talk on that and give some examples. If you get the chance, this book by Freeman Dyson called The Scientist as Rebel is really entertaining, honestly. And it talks about how science is really a rebellion. It's a rebellion against the status quo, because if you were happy with the way things are, there would be no questions to answer with science. And so as a scientist, you are de facto rejecting the status quo, which makes you a rebel. And maybe I just like to call myself a rebel that way, I'm not sure. But nevertheless, it is an interesting way to think about it and a fascinating book if you get the chance. So for me, I've been rebellious and awkward for some time now, and started this journey about almost 20 years ago with my first idea, which was called Dizzy Fix, which was a device to treat the most common cause of dizziness, actually. followed by another one, which is called ClearScope, followed by another one, which is Shoebox, followed by another one called Modica. And I've been involved with a research institute for a while now, trying to help solve the problem of innovation. So the issue really is that we in healthcare have a problem. And one of the problems is my dog is barking. So let me just sort that out. There we go. You can also meet my dog there. Problem of working from home. So we have a serious problem, which is, oh my gosh, give me 1 second. Okay, here we go. We're back. Population's getting older and the healthcare expenditures are going up, as you can see in the diagram. Now, these numbers are actually from 1997 and the things have only gotten worse. And so what do we do if we have an increasing population who needs healthcare and simultaneously increasing costs of healthcare? It becomes a serious problem. And a lot of people, if you survey them, the answer in these word clouds, you can see innovation, technology, comes up a lot. Okay, but what is that exactly, and how do you do it? This is a fun quote from Henry Ford that came up in his biography. If I asked people what they wanted, they would have said faster horses. I guess, Steve Jobs also appreciated this in that he didn't ask people if they wanted, a magical mobile device. He just made one and then people wanted it. Because people don't necessarily always know how they want their problem solved. They just know what their problems are. And so sometimes it's important to not jump to the solution too quickly, but really understand that problem in order to come up with something that isn't just an iterative improvement on the status quo. We really have this problem in healthcare because to a large degree, we don't do that here, which was a shock. Like, I thought healthcare and universities were all about doing this, but my journey started in 2005 when I took my invention to the hospital and they said, we don't do that here. And I was so distraught that basically it's taken me 15 years to recover and try and figure out how to do this. The picture on the right-hand side is an AI generated image when I put in Canadian innovation, and it came up with a blind doctor trying to figure out how to cross an easily passable barrier, which is a bit shocking and distressing. So there are a lot of opportunities. This is how CHEO maps out its values and, the strategic directions, outcomes, evidence, partners, connecting care, unlocking our potential. And my point here is each one of those things we value creates an opportunity to improve. And so innovation can play a role in any one of the strategic priorities of any organization. I think that's important because aligning with your partner is really important to make progress. Because if you're fighting against them, you're not going to get anywhere. Funnily enough, innovation can help prevent burnout in doctors or in anyone really, because the most frustrating position you'll ever find yourself in is actually responsibility without power. And you've probably had a job like that in your own life where you get this huge responsibility and you're operating within a crazy system that does not work at all. And you have no ability to change that system. And then you're like, well, this is a terrible job. But if you give people the ability to innovate and improve their own circumstances, not only do you get better outcomes, but you get a better system and you get people who aren't burnt out by their job. And so this is something that we need to really embrace in healthcare. I like this because I was actually just in San Diego at an innovation conference and I was watching the surfers surf. And you've heard about, innovation as a wave before, maybe. But I think what's funny about it is that all those surfers, if you look at them, one is surfing the wave. All the rest of them are kind of either didn't see it, they're dodging it. They're going to catch the next wave. They weren't ready for this wave. And maybe 3 or 4 people tried to catch this wave, but a bunch got crushed at the beginning. And this guy, even if he does well for a while, eventually is probably going to have a rough ending one way or another. And innovation and startups kind of like that. You miss a lot. You didn't even see a lot. You tried but failed. You tried and it worked for a while, but then you got crushed by the wave. And so, I thought it was a really interesting analogy for thinking about innovation, meaning you don't have to catch everyone, but you should keep your eye out for opportunities. I think Charles Kettering, who also has a fascinating biography, if you have a chance to read about this guy, he invented things like windshield washers, which was cool, baby isolettes, air conditioning in cars, all kinds of stuff. He was an engineer, and he actually worked with Sloan, who was a doctor, to create Sloan Kettering, which is a huge cancer treatment hospital in the United States. But he felt that you need a certain amount of intelligent ignorance to get anywhere, meaning that if you knew too much about how hard it was going to be, you probably wouldn't do it. And so sometimes if you have the tools, but you're not afraid to start, you can get going maybe a little easier. So how do you get from your idea to your innovation, and what do you need? Well, it's useful to define what innovation is. It's not just an idea, it's what happens when you apply people and time and resources to your idea to create products and services. And there might be different kinds of innovation as well. You've all made small changes in your house or your car or your home routine, and you might think, oh, that's an innovation. Okay, sure. Let's call that routine, incremental innovation. You might have heard the term breakthrough innovation, where a significant technological change in an innovation happens. You probably haven't heard very often anyway, maybe translational research, but translational innovation, let's talk about that. You probably heard of disruptive innovation. They talk about Uber and things like that really disrupted an industry because of a business model change. And I'm sure you've not heard of architectural innovation, transformational innovation, foundational innovation. These are all other terms or different types of innovation. Now, what do they mean even when you talk about that? So let's look very briefly at that. But if you make a cube of all the innovations, bottom left-hand corner, this is routine. You haven't changed the business model. Can you guys still hear me? I got some weird alerts on my screen. It's still okay? This thumbs up there? Yeah, okay. Maybe you haven't changed the technology, and you haven't changed where it lives. The ecosystem hasn't changed. This is routine. You made a small change. But if you change the business model, Uber becomes disruptive. You change the technology, you move from a CT to an MRI, it's a breakthrough. You change both of them, it becomes architectural. You might think about how Netflix has eventually become up here because they changed it to streaming, and they changed the subscription from the way you used to go to Blockbuster and rent a movie. So it's quite different. But then you take all that and you move it to a different ecosystem. So you move it out of entertainment and you put it in healthcare. You've moved ecosystems, which adds complexity. And when does that happen? For example, the surgical safety checklist used to be just the airline flight checklist. It's not a new technology. It's not a new business model, but it is in a different place. And what happened in planes, they used to say flaps, check, brakes, check, fuel, check. We actually now do that in surgery. Patient, check, side, check, operation, check, to make sure we don't make those mistakes. And that sounds like such a small thing, but you would not believe how hard it was to do that. And it was easily demonstrable that it had a gigantic improvement. But just because you changed the context, it became difficult. And so when you think about your innovations, trying to do too many things or too many accesses at once becomes very hard. And it might be worth scaling it down and say, you know what, we're going to innovate around the business model, or we're going to innovate around the technology. Maybe don't do both, at least not simultaneously. So again, Henry Ford, a fascinating, kind of strange man sometimes. Although if you've used those charcoal briquettes, Kingsford charcoal briquettes, I think it's funny, Kingsford was a friend of Henry Ford, and Henry Ford had these piles of sawdust, and he didn't know what to do with them. And so his friend Kingsford was like, I could make a charcoal briquette out of that. So Henry Ford gave all his sawdust free to Kingsford, and you still buy Kingsford charcoal briquettes today. And it's weird that this partnership across industries created a new industry. And that's kind of what this talk is about. How do you find creative ways to use things like sawdust? But in this quote, Henry Ford says, not all ideas are good ideas, and there's no progress in finding a better way to do a useless thing. So, sometimes be careful. But it is so difficult. I really like this. This is what's called the Lippit Knoster Model of change. And it says how many different ways things can go wrong. You need a vision, you need skills, you need incentives, resources, and an action plan. And if you miss any one, it creates a problem on the right-hand side of different kinds of problems. And you probably in your own work seen false starts, or being frustrated, or encountered resistance or anxiety or confusion because of some of these lacks. So how on earth do you do it? How do you come up with good ideas? it isn't necessarily about, and this is a great book if you enjoy thinking about innovation, it doesn't necessarily come from a light bulb, but it comes from those connections between people. Like if, an engineer and a doctor sit down together, they're probably going to come up with an idea, of some sort about something, because you created the space for that to happen with people with different skill sets. At Shoebox, which is one of my companies, we have these hackathons occasionally, and partly they're to fend off burnout, because it's fun just to talk about. So I had this idea, will it go anywhere? You can look at new technologies like AI and how do we use that in our workflow. So, it can be a boost to how you feel and innovative thinking. It helps, take a break, but it also creates those opportunities for the engineers to talk to the salespeople and the salespeople to talk to the operational people and kind of collide those thought worlds where somebody who says, well, I have this kind of problem, and somebody else can say, well, we solved that kind of problem in our, doing this, which was completely different. Because you don't always have to reinvent the wheel. You can borrow somebody else's wheel, so to speak. I talk a lot about this in this other podcast through Backtable. So if you're interested in how intelligent ignorance, so to speak, is involved in solving the problem of, we spend a lot of money on research, but we don't spend a lot of money on doing anything with that research. And I liken that to not eating your own cooking. Imagine you spent all day making dinner, then at the last minute, you threw it out and you ordered Uber Eats from the United States. Why would you do that? But we do that all the time in Canada. Mostly because we haven't solved the problem of connecting the people that need to talk to each other. This is from the Canadian Medical Association Journal, actually from quite some time ago, 2009, where the then Minister of Health wrote that we seldom move proven projects into sustainable funded programs, and we rarely transfer the outcomes of pilot projects across jurisdictions. So that means even when we get to the pilot phase, and we did it, and we demonstrated that the fruits of our research actually work in real life, and like success, let's stop. Shocking. My favorite example of that is actually the Jefferson Memorial in the United States. It's the round one that sits on the water. It's in a lot of movies in Washington, D.C. And it's white. And it had a lot of bird poop on it. You might have heard this before. It's the origin of the 5 whys. But why did it have bird poop on it? Because, and they had to repair it a lot. Because they always hosed it down. But why did it have bird poop? Because it had spiders. And why did it have spiders? Well, because it had flies. Sounds like that song. Why did it have flies? Because they turned the lights on at dusk because it looks pretty. And so like, oh gosh, well, we can solve that problem by turning the lights on maybe half an hour later. So they did. And they did a 3-month study demonstrating that the amount of debris on the monument was reduced by more than 80% by simply turning the lights on half an hour later. They succeeded at their pilot, and then they immediately stopped doing it because they liked the way the lights looked at night. And so, despite the evidence to show that innovative solutions can solve problems, it doesn't always work. I interviewed a lot of physicians about why they're having trouble. They have pretty good at the beginning, empathizing with their patients, defining their problem. They're pretty good. But as soon as you get into ethics and research, their satisfaction level drops and they're like, oh, this is tricky. But then they're doing their research and they're doing okay. But then they're trying to get started with developing this into a product and, they don't know how to do that. And then like, yeah, but we can sell it this way, but then they scale their business and then it's really difficult. So there's sort of 3 key areas where physicians are having difficulty, or healthcare teams are having difficulty moving this along. And, you have this strategy in your head, I'm going to go there, and people call that the North Star, and it's kind of a straight line, but obviously that it does not turn out that way for so many different reasons. And any of you who have been involved in a startup company know how treacherous this can be. I talked to Ian Hennessy, who's the head of the innovation program at Alder Hey, which is one of the UK's premier innovation or innovative hospitals. And they have a big program, a team of about 50 people doing this. He says his least favorite thing is innovation diagrams, because they're like, it's nothing like that. I don't know why they bother drawing it. It is not like that. And so I added the X to this slide because, often the administrators will say innovation at CHEO or wherever you are, and they'll have 1 arrow, and it's just not like that at all. Sometimes they'll have more than 1 arrow innovation, and it's not like that either, which drives me crazy. This is our diagram, and it's tricky because it's complicated, but sometimes, particle physics is complicated. It doesn't make it not true. And we start with ideation, understand your problem. It moves on to incubation, which is a bit different than the business term of incubation, but this is more like prototyping, figuring out how does this solution potentially work. R&D, which is iteratively improving and validating your solution, commercializing, growing your company, excuse me, and implementing it back into healthcare at the top. And it's a multi-stage, multi-step, multi-person kind of problem. It's a team sport. This is an article from the New York Times. It really is. There's that idea about the lone genius, be it Nikola Tesla or whoever, Thomas Edison. It's really not true. And I tried to put that whole cycle in the hospital previously. And the answer I got, just as a reminder, is we don't do that here. And I didn't understand. I was like, well, but I have it solved. We have to do all these steps and then we're okay. But what I didn't realize at the time is they were right. We don't do it there. We do parts of it there, but we don't do other parts of it there. And I think that's one of the things that's really nice about this conversation is I live in the purple healthcare one. Many of you live in the yellow business one, and still others, Andrea lives in the green one. And if we don't overlap at all, we're not going to go anywhere. And what we need to do is to take that and we need to move it to look more like this, where there is at least some overlap. Andrea is not going to start doing surgery, I'm not going to start being a professional researcher, although I do some research because we overlap. We don't have to do each other's jobs, but we do have to talk to each other. A shout out to my daughter who might be on here. This is her diagram. She's doing some work with us over the summer, and I stole it with permission. So I should put that on the slide, actually. My point is, if you're the person on the left, an engineer maybe, and you're working in isolation on your computer and you think things are going great, you run the risk of missing the mark. Whereas on the right-hand side of the screen, as you look at it, I hope, there is technology interacting early with patients and early with clinicians to try and figure out, is this the right solution and how do we improve? And that early contact, I would say, is the evolution of innovation. Innovating in an ivory tower is not so useful, and the likelihood of it being fruitless is higher. So, wow, yeah, now it gets complicated. So what did I do? I took that 6-step process and I put it over the 3 ecosystems to indicate what you should be doing where. And just as a review, in healthcare, which tells you about, is this a good idea? You should be thinking about your ideas. That makes sense. In the R&D, which is the research one, which tells you, is this feasible? It's what you should be doing. That makes sense. In growing a business, you should do in the business ecosystem. That makes sense. It's really the ones that cross between ecosystems. Incubation. Ask a doctor how you 3D print something to make a prototype. Well, they don't know. Ask a researcher how you start a company. Mostly, they don't know, and they don't have any money for it either. And ask a business how easy, and this one, how easy is it to sell into large hospital systems? It is terribly, terribly difficult and takes several years, right? Because there's a collaboration gap. So even though this is a nice Venn diagram, it kind of doesn't, it still doesn't feel like this, even though it looks good. So, for those of you that like suits, I don't have dreams, I have goals. What does that mean? It means converting your thinking into a strategic plan, which is essentially what we did at CHEO. We tried to build we have built our own innovation ecosystem at CHEO, bringing these parts together, which is one of the reasons we're talking to each other now. And so we're going to spend a few minutes now with Andrea talking our way through what project are we doing now and why are we doing it this way and what are the outcomes of that and how is this leading us towards innovation. So Andrea.
Great. Thank you, Dr. Bromwich. I'm Andrea Pepe.
I think you're muted maybe, Andrea, or my speaker's down. Oh.
Am I okay? Okay, great. Thank you, Kimberly. Yes, so I'd like to take the next few slides to briefly explore an innovation-led collaboration between our teams at CHEO and at Thrive to address a long-standing challenge of overcrowding in the emergency department at CHEO. To the next slide, please, Matt. Oh. This might be a problem if he is unable to hear me.
I can hear you now.
To the next slide, please, then. Okay, so in the late fall of 2022, CHEO recorded the highest volume of patients in its history due to a surge in respiratory infections in the community. As a result, CHEO was operating far over capacity, which caused interruptions in care, delays in surgeries, and historically long wait times in the emergency department. Now, unfortunately, overcrowding is not a new challenge. Rather, the surge highlighted a longstanding issue that is faced by both patients and clinicians working in the emergency department. To highlight this point, a group at CHEO in 2015 surveyed 2,000 patients waiting for care at the CHEO emergency department, and they found that 41% of these visits were actually considered low acuity. Furthermore, only 11% of visits actually required interventions and services best addressed at the emergency department, as opposed to services that could have been provided at a primary care or community clinic. And in addition to that, a third of patients reported that they did not try to seek alternative options to care before presenting to the emergency department. And of those that did try, the most common reason why they did present to the emergency department was a lack of the ability to access a timely appointment to be seen by a clinician. To the next slide, please, Matt. Now, this all does highlight the overarching problem that we face. So increases in visits to the emergency department, particularly those of low acuity that could have been seen in the community, plus a lack of knowledge about or accessibility to timely community resources, results in this overloaded pediatric emergency department issue that can contribute to clinician burnout and to patient distress. Now, when you add on a stressor like the surge of late 2022, this shows that the system is far overloaded and not built to handle that kind of a stressor. To the next slide, please. All right, during the surge, CHEO implemented a variety of solutions to try and respond in the most timely manner, including investments in personnel, improvements to their operations, and enhanced communications about wait times and the overall situation of the emergency department at the time. Now, these solutions helped to respond to the surge in the short term, but didn't directly change the community use of the emergency department. To the next slide. Now, in the project that we're working on with Thrive, we propose an app-based solution to help guide patient decision-making and provide information to access care at the most appropriate resource at the time. At its core, we envision that this app will allow patients to input symptoms and be presented with the most appropriate location or option for care in the most timely manner, and even allow them to book an appointment at the first opening to be seen as soon as possible. By helping to guide patient decision-making, we hypothesize and we hope that this solution may improve timely access to care, both for those seeking care in the emergency department, as well as in the community. And we hope to also help to reduce wait times in the emergency department and ease an overburdened system. To the next slide, please. Now I'm going to mimic Dr. Bromwich's figure here to represent how each of the innovation ecosystems is crucial for this project's success. By leveraging Thrive's existing technology and their expert development team, by leveraging the insights and expectations from the patients and clinicians at CHEO, the population who would be most impacted by the implementation of this solution, and through rigorous and iterative research at each stage of development and launch, we aim to have a final product to be accessible and clinically validated decision-making tool that is tailored to the unique needs of the population that CHEO serves. To the next slide, please. Now we are in the early stages of discovery with this project, meaning that we have had our first touch point with patients to garner what their expectations would be for this type of a product. And we are going to use that data as we move into the development stage to help inform that development process. Now, even this early in its process, our team has gained some very valuable insights, namely that it's very important to figure out and speak the right language and have a shared vision. It took us a bit at the beginning to find our stride, but once we did find it, partners from all of our innovation ecosystems are able to come together at the table and have discussions that are extremely productive and setting ourselves up for the best possible success. We also learned that persistence is key in that certain parts of this project, whether at this stage or future stages, may provoke a change in the ecosystem of the institution to help our project and future projects thrive. And last point, we did also learn that research and innovation doesn't necessarily end after one phase. It doesn't stop with a pilot. Rather, it's an integral piece from both discovery to clinical validation, and even to support post-market implementation and beyond. And I do hope in the future that I'll be able to share the successes of this project, but for now, I'm going to turn it back to Dr. Bromwich.
Amazing, thanks. And it has been great working both with Thrive and with Andrea, trying to bring these pieces together, these worlds together, because it's really the only way forward. But despite that, solved, not so fast. I don't know, at a conference somewhere, and I was just thinking about this, and I scribbled this literally on the back of a napkin. And this is the phases of sort of an idea. And phase one, I'm sorry for my writing. This is a photo of the original drawing, excitement, and then kind of this, everyone gets kind of scared and down, and then eventually it works, and there's a productive collaboration later. So I thought this was my own model. I had put it up in a talk some years later, and somebody said, that slide with the Gartner hype cycle. I was like, the what now? And it turns out this is called the Gartner hype cycle, which somebody else has published on and defined, where you have phase one, where there's that enthusiasm and excitement, and maybe you'll leave this talk with enthusiasm and excitement, and you'll go away and you'll start your project. You're going to hit that phase two of disillusionment and uncertainty, where you're like, this is never going to work. And I liken that to you're renovating your bathroom. You're all excited. You go to Home Depot, you buy all the stuff, you come home, you tear down the first wall, and you see all that black mold and like paper insulation and rusty pipes. And you're like, oh God, what have I gotten myself into? But eventually, over time, with sustained effort, you get to that phase of acceptance, collaboration, and impact. So, it's doable. But change is hard, even if you have a better wheel. People are busy. This guy's busy doing his square wheel thing, and hospitals are like that. And the more risk, the less innovation. So as you increase risk, the innovativeness goes down. And literally, people have said this to me before. Your proposal is innovative, but unfortunately, we won't be able to use it because we've never tried something like this before. And the irony of that, So how do you get around that? The problem with healthcare as an industry is it's a ship. It's a giant ship. And answer this question yourself. How well does ships turn, right? Not well. Right? They can't turn on a dime. So what's the solution to that? Smaller ships. So if you have a fleet of healthcare or safe places to try out things, or they call it a sandbox in some places, you try it out somewhere safe. You try it out in a clinic. You try it out in a small hospital. Anything you're trying to do, try and do it at a provincial level is very difficult. And I know that Thrive has tried to do many things at a federal and provincial level, and it's very difficult. And, you probably had success at small clinics because it's easier. So this is just a sort of truism at this point. But when you think about these hospitals that are struggling, it's not the strongest that survives, it's the most responsive to change. And I wish we could get this through our hospital healthcare system, is that for the treasured Canadian healthcare system to survive, it needs to change. Otherwise, it will not survive. So innovation, sure, we got that solved. An ecosystem or 3 ecosystems, sure, we got that solved too, but somehow it's still not quite right. I found this diagram, innovation, that straight line, but it really doesn't feel like that. Why does it feel so squiggly? And even when you draw your nice diagrams, why is it so different? I tried to add one more dimension, a third dimension to my diagram. So now there's 3 of them, these floating in space. And the next pictures that you'll see, I haven't moved these. I'm simply going to rotate this image, and you'll understand what it means to have a different perspective on things. Excuse me. Here it is. Looks like they overlap. And people will often say, Matt, you must be that star in the middle. You're a star. It's great. It must feel great. It feels terrible. Why does it feel terrible? And the reason is this. If you rotate that 90 degrees, these don't overlap. They don't even overlap at all. So if you're in the middle, you're in the middle of nowhere. No one understands you. No one speaks your language. You don't have any friends, and you're kind of a pain to everybody because you ask the hospital to do weird things. You ask the businesses to do weird things. You try and do things that put you in conflict of interest with the research department, and you're nobody's friend. And it's frustrating. And the distance between healthcare and business is so great, and the journey is so perilous. How did that happen? So I'm going to rotate it again to give you another perspective. I'm just going to twist it up. And in the next view, I guess I'll go back because I want to say something about this. So this, there's a lot of steps. And per the reverend here, perseverance across those steps is not just one long race in a straight line. It's multiple steps, multiple races, and you have to persevere over time to get through that. I've rotated at 90 degrees. This is how the researchers see it, or at least the Research Institute. They're used to businesses coming and doing industry-funded study. They're used to doctors coming and doing research for knowledge creation and patient evaluation. And so they see one or the other. But if you're both, and literally I'm both, I have a company, I've developed an innovation, I'm a doctor, I'm doing a research project, and they're like, well, you know, which one of these are you? And both. And they just, it creates chaos. And yet you rotate this again, and this explains why it looks messy, because it depends where you're standing. If you stand over on a 45-degree angle, you know, the map looks really messy. And there seems to be overlap between research and business, because they both, you know, you look at some of your research partners, they're selling molecules and inventing insulin and selling it to Johnson & Johnson. That's a business, all makes sense. But how does healthcare not involved in that? And still other views, it looks different. But hopefully this crazy maze of chaos that we're trying to navigate isn't so crazy if you can follow along behind someone who's done it before. And so that's what we're trying to do at CHEO, is to make sure that this pathway is well defined. So when it looks messy like this, we can say, it's okay, you know, this is how you navigate that. And bring them back to the spot where you're standing here. And it just happens to all line up and you're like, oh, I see what I'm supposed to do next. And the first thing you do, and everyone does, is they make their logo and buy t-shirts. But does that really advance your agenda? Probably not. And so really maybe the first thing you should do is make sure that your problem that you're addressing is the right problem. And maybe go talk to your research people and say, is this even possible? And you go talk to your business people. Is this even viable? And you talk to your doctor people and you say, is this important and desirable? Before you even really start, before you get the logo, before you get the t-shirt. This and many other things. So yeah, it's complicated. So is the London Underground. But what you need to know is that where you're standing and where you're going. And then this becomes very useful. But if you don't know those things, it's not very useful. And so same in this map. Who are you? Where are you standing? Where you're going? You know what to do next. Simple as that. You know, I've seen this in several other people's talks since all models are wrong, but you know, I hope that this is useful anyway, at least. So growing is hard. You've seen these adoption curves, and particularly the space between early adopters and the early majority is where the funding drops off, because you're not a research project anymore, but you're not a viable business either. So it becomes tricky. And so, you know, you can fail a lot. I crossed out failing and put the word learning, because it's not, you're not intentionally failing. But if you fail and don't learn, then you really failed. But if you failed and learned, you know, this is just a deviation. So was it a good idea? Did you ask those questions of your friends? You know, sometimes that happens when you have that slow hunch. You keep on noticing the same thing over and over again. Sometimes you're bored, which is why boredom is so useful. And we need to be more bored instead of looking at our phones all the time. Sometimes you'll meet that courageous leader who's like, this has to change. And I wish, honestly, I wish I was more like that sometimes. But usually I'm the last one, desperation and ignorance. And whatever it is that you've done is so bad that you realize, wow, we really need to do this. And the reason that is a freeing position is, well, what do you got to lose? You know, you're already the worst. And a great example is the London, Ontario emergency room was the worst in the province. And so they were in that position of desperation. They said, well, we got to do something. So you know what they did? They took all the triage nurses, all of them. They had no triage nurses at the front where you go check in, you get triaged and emerge. And they put all of them on patient care. So there was literally a sign at the front door that said now, and you walked in that door, and later, and you walked in that door. And they just let people figure it out themselves. And they dramatically improved their ER wait times. You know, but had they been 17th instead of 68th, they probably wouldn't have been able to take that risk. With that being said, you know, changing everything, as we talked about before, changing too many axes of your cube makes radical change. And it's difficult, it's likely to be rejected. And if it's a minor one, like it's that incremental change, often it's ignored. That's not a big enough thing for us to really spend time on. I'm going to skip over this one, but value comes when you have an outcome, which is you lived or died, times your experience of live or dying over how much it cost. for you to live or die. And innovation can happen in any one of those. So maybe you improve the outcome. Instead of dying, you lived. Amazing. Your experience, instead of having a horrible experience in the emergency room, your experience was great. Or maybe you decreased the cost. And so this Michael Porter's publication here really crushes down all the economics of healthcare into a single equation about, well, how do we value our health and healthcare, and where are the opportunities for innovating? I had some bad ideas. Maybe they're good ideas. I don't know. This was back in 1999, before Red Bull, as a note. And I just finished medical biochemistry, and I had figured out all the ingredients necessary to prevent a hangover. And I had a two-part drink. Part one you drink before you go out, and part two you drink when you come back. I thought it was a great idea. I called it Last Call. And I never did it because for me, I didn't see the value. But interestingly, nowadays, you can buy those energy drinks and those, like, I'm going to call it a resuscitation drink. And they often have them together in hotel mini fridges. So you can drink one before you go out. And so maybe it was a good idea. I don't know. I thought about putting bugs in people's ears to cure a disease called a cholesteatoma that's caused by skin cells. You know, that seems, let's be honest, gross. And I thought about resolving one of the most common problems we had in the general surgery floor, which is essentially constipation due to surgery, or what they call the functional bowel problem, by using this vibrating belt, you know, those weight loss vibrating belts to kind of, excuse me for saying this, but shake the shit out of you, right? Like, why not? I also never did that. But, you know, they're kind of fun ideas. Oh yeah, there's that, you know, essentially the thing that I never did. I should animate that differently. But my point about that wave is you have to be ready. Chance favors the prepared mind, says Louis Pasteur. So if you're not ready to catch that wave, it will just go by. And so if you're trying to impact this in healthcare, show your impact. You know, don't tell it. But DizzyFix, which is my first one, has treated more than 10,000 people with the most common cause of dizziness, and is now available on Amazon. Although I sold the company a long time ago, I don't really have a conflict anymore. You know, ClearScope was a way to hook up your cell phone to an endoscope and save several lives that I know of. We don't make it anymore because scopes have changed and things like that. But it was fun to talk about how that kind of communication improved lives. And Shoebox has treated millions, actually six and a bit million people with hearing conditions now. And so CHEO, where I work now, is just full of problems. And healthcare in general always will be. You know, clinic wait times can be 6 to 9 months. We have more than 1,000 people waiting for a hearing test, shockingly. ER wait times can be 15 hours or longer at some points. And so how do we do that? You know, maybe we need a revolution. And if you're interested, I actually just read this book, The Bomber Mafia. It's about in World War I, how even things like having planes in the military was poo-pooed. You know, what is a plane for? This is the army. You don't need a plane. That's just a toy. Until the planes started dropping grenades on the enemy, and then they were like, oh, this is actually pretty good. And so getting the airline pilots together with the military, you know, birthed this revolution in conversation, argument, validation, and proximity. And, you know, it may be that we don't need a revolution in healthcare, but we do need a revelation. We need a new way of looking at something, or maybe we need a rebellion, kind of how I started. A new way of thinking about how we innovate that moves away from thinking about maybe we'll just wait for one genius somewhere to come up with something and then we'll order it Uber Eats from the United States. Instead of doing that, maybe we'll come together and work together in a systemized way that supports a graduated change through these ecosystems and leverages the skills, honestly, we already have. We already make dinner. Why can we just not eat it? So a few tips: start with your problems. You'll get better answers. Don't ever come with a solution, because then you'll just have an answer looking for a problem. Lead with impact, because if you do show the impact that's happening, people are more likely to say, you know, actually, wow, I didn't realize that. Maybe let's give that a go. And partnerships, bringing those colliding worlds together, are really where it happens and unlocks that journey. And so if you're to leave with some rebellious thinking about how to get from idea to innovation, I would leave with those three things. And I think one thing you can be proud of yourselves for, if you are involved with CHEO, the RI, or at Thrive, is that honestly, that's what we're doing. That's your everyday job. That's what we hope for. So I hope that you think about that in your own lives and your own work and realize how valuable that is. So if you do like to get in touch with me, there's my CHEO email. I started an Instagram called Let's Innovate Health, and just recently. And if you'd like to follow along where we talk about some of these problems, please do so. Otherwise, I'll hand it back and we'll take any questions. Kimberly.
Amazing. Thank you so much, Andrea and Dr. Bromwich, for your wonderful presentation. I do see that we have some questions in the chat and that Dr. Bromwich has provided some written responses to those questions, but maybe I'll ask a couple in case, Andrea, maybe you'd like to add something or Dr. Bromwich would like to expand. So maybe we'll start with this one. Are there any special considerations when thinking about technology and children's health?
Yeah, I think one of the problems with pediatric care is that you essentially have two patients, don't you? You have the parent and the child. And particularly from a consent standpoint, it's tricky because the child can't consent for themselves. You know, if you have an app or a form, they're not filling it out for themselves. There's always a proxy. And at the young ages, you know, we assume that the adult provides an accurate response, but they don't always. They don't know what's going on inside the child's body just because they're their parent. They can't tell you if the pain is better or worse, you know, necessarily. It becomes subjective instead of objective. And at the older range, it becomes tricky too. So you have your 12 or 13-year-old who doesn't want their parents to know what their situation is. And so, you know, yes, it's different. It is more complicated because of that. And, you know, essentially what I had written there as well, which is pediatric research in healthcare is often and surprisingly underfunded by contrast to adult because it seems to get marginalized a little bit. The same is true with elder care. And it's odd, and I think it's only a function of the people making the decisions generally are adults. They're not children and they're not retired. And so people, I think, can't help but make decisions in their own favor. And so we miss the edges. And so I used to work with a painter when I was a teenager, and he would say, you know, Matt, when we're painting a wall, if you look after the edges, the middle kind of takes care of itself, because I was in the middle, you know, painting the middle. And I think that common wisdom applies to healthcare, which is if you look after the edges, the middle kind of takes care of itself. And so maybe we could improve this situation by focusing policy on the edges a bit more intentionally.
Thank you. I just saw another question come in. What role could post-secondary education play in regards to encouraging or even teaching innovation in healthcare?
Yeah. Do you know, I mean, I'm going to ask Kim, do you know why they teach languages in high schools, Kim?
I do not. I didn't take one.
Oh, okay. Anyway, but for people who took Spanish or French or whatever, the concept is to expand your horizons. And it gives you a different way of thinking about the world because it gives you different words. Oh, we don't have a word for that in English. How many times have you heard somebody say that? Or, you know, in French, we call that whatever, but there's not really an equivalent. It gives you a different toolbox. And I think one of the challenges is by having a very narrow and rigid system in healthcare in high school, you miss out on that. And so a lot of being good at entrepreneurship and innovation is about connecting people and things and ideas and having that open discourse around ideas where no idea is a wrong idea at the beginning is really important. And so I think in medical school, do we have any classes on innovation? No. Do we have any on business? No. So how do I talk to a business person when I have no language to talk to that business person? How does a scientist talk to a business person? How does a researcher talk to a healthcare person when they've never done a clinical interview and they haven't done any skills with patients? Like, you just don't say the same things. And as a result, unfortunately, you develop prejudices. And it's almost a bit like interprofessional racism, if you will, in that we don't understand each other in the way that we'd need to collaborate. So.
Thank you. Andrea, do you have anything you'd like to add?
Yeah, I would like to add on to that as having an outlet for innovation earlier on can also give a way to use critical thinking skills that every course syllabus would say you are taught in the course. And that can span, as Matt said, between business, between your sciences, between your social sciences, and it can set you up for success when you leave an academic setting and realize that you are now on your own, needing to put those skills to the test, essentially. So I believe it could be very beneficial for a different outlet and a different way of thinking.
I see another question there, which says you talked about how messy innovation process can be. What's the most important barrier to overcome and increase the chances of successful innovation in Canadian healthcare? I'm going to, just for the purposes of illustration, jump back to this. That was not the quickest way to do that, this map. So if this is the map, and you were to throw it away or close your eyes or not look at it, and then I were to ask you, how do you get from Earl's Court to Dalston Junction? You don't have any idea. Now with the map, it's complicated. You got to make 2-3 changes or something like that. But it's possible. And so I would say an awareness of the process is probably the biggest barrier. Because if you don't think it's a thing, you can't even have a conversation about it. And I would say most organizations think it's one thing. And at a minimum, I think it's 6 things. And they think maybe, well, interestingly, they think they don't do it there, but they do part of it there, but they need at least 2 other partners. So if you do 6 things across 3 ecosystems, it's just more complicated than let's innovate at our hospital or our organization. And so some basic understanding of the process and an awareness of the complexity enables you to then create an ecosystem where you intentionally place supports at weak points and say, hey, you know what? Great idea. Bet you don't know how to do anything about that, but we have somebody to help you. Or, hey, great business product. Bet you don't have much money for startup, but we can help you. Or maybe you say, hey, great business, but our hospital's not very good at buying that kind of stuff. Why don't we help you? There's key points you could intervene once you know that it exists. And I would say most of the time people don't know it exists.
Wonderful, thanks. So I think that was our last question, and we are just about at time. But before wrapping up, on behalf of Thrive, I do want to extend our sincerest gratitude to all of our attendees, esteemed speakers, and panelists for making the Thrive Health Ground Round Speaker Series a success. Your active participation and insightful contributions have generally enriched our pursuit of interprofessional learning and knowledge exchange. We'd also like to express our heartfelt appreciation to our fantastic speakers today, Dr. Matthew Bromwich and Andrea Pepe, for their expertise and valuable perspectives on addressing barriers to implementing innovation in healthcare. And as we conclude this event, we encourage you to continue your pursuit in innovation and collaboration. Together, we can shape the future of healthcare, breaking down barriers and embracing innovative ideas to drive meaningful change for the betterment of patients and providers alike. Once again, thank you all for your participation. And for any follow-up questions or additional inquiries, please feel free to reach out to us at marketing@thrive.health. Your feedback is valuable as we strive to refine and improve our future events. So until we meet again at our next Thrive Health Ground Round Speaker Series, we wish you all continued success in your respective endeavors. Thank you.
Thanks so much for having us.